Hey, welcome to the Healthcare Nation podcast. Rick Giannotti here, and I'm your host. And as we go into episode 2 of the Big Challenges chapter, we're going to be looking at healthcare equity and disparities. It's a big topic, and I couldn't be more pleased with the guest that we have, who is a content expert in the field, Dr. Ram Raju. So Dr. Raju began his professional career as a surgeon in Brooklyn, New York. He went on to serve as chief operating officer and medical director for New York City Health and Hospitals, Coney Island. He then went on to become the corporate chief operating officer for health and hospitals. From there, he went to Cook County Hospitals in Chicago, the nation's third largest health system, public health system. Had an incredible run there before being asked by Mayor Bill de Blasio to come back to New York City to serve as the CEO for Health and Hospitals, where he served until 2016. He rounded out his health system tenure as vice president and community health investment officer for Northwell, where he was charged with evaluating the needs of New York City and Northwell's population's most vulnerable communities and providing solutions for them through very innovative collaborations, which you're going to hear about in the podcast. Dr. Raju also served as vice chair for the Greater New York Hospital Association. He's on numerous city, state, and national boards, including the American Hospital Association and the New York Academy of Medicine. It is going to be great to have Dr. Raju on the program. Really quickly, the opinions expressed on the podcast are those of the host and the guests, and certainly not intended to apply to any organization, academic, or business. And they're meant for informational purposes. With all that said, welcome, Dr. Ram Raju.
Oh, thank you, Rich. It's nice to talk to you. And I really want to congratulate you both on starting a podcast, which is such an important issue, is addressing some of the important issues in healthcare. And also, most importantly, choosing health equity as the starting point, because that's really unusual in healthcare. Usually, people look at the health equity somewhere down the list. But I am so happy and proud that you recognize health equity as a central piece of the challenges we have in the healthcare delivery system. So I've been continuing to spread and hope make the healthcare more equitable to everybody. And I come to the conclusion that you cannot really create a health equity in this country without addressing the social equity in this country. So that's why I always said for a long period of time, Rick, that there is no health equity without social equity. And social equity means that we need to create opportunities, economic opportunities for people to do that. So unless they create economic opportunities, attain social equity, health equity will be an issue. So that has been my message for the last, I would say, 21 years of my life I spent on this particular area. And I'm very happy to say that it is getting a lot more traction in the last 4 or 5 years than it ever had in the first 15 years, which I call them wilderness years, where I was kind of going around talking about it and people didn't really either want to hear it or they don't understand it, or I was not communicating that very well. But I'm happy things have changed. And the fact of the matter that it became the central beginning topic of a national podcast like yours, I'm very happy that we are really making huge strides in addressing the health equity in this country.
Thank you so much for those comments. And let me tell you, as I said, I couldn't think of a better person to speak to the issue. And I agree with you with respect to the topic. I think we've got to pick up the big challenges, and clearly this is one of them. I wanted to start, though, with, better health equity through social equity, your op-ed piece, the piece that you wrote in the Chicago Tribune. Why is this issue so important for you? Your passion around it is visible. So let me just start there, Ram.
Sure. I think like any other immigrant doctor into this country, I'm a surgeon by profession. And if you would have told me I would be interested in population medicine, community health, health equity, healthcare disparities about 20, 25 years ago, I would probably say, hey, that's not going to be, because I was a practicing academic surgeon involved in research, teaching, and running a residency program, affiliated with the medical school, trying to, attain the ranks of professor, which I ultimately did, and all those things and taking care of patients. But a life-changing experience happened to me when I happened to be taking care of an Hispanic woman, middle-aged Hispanic woman who had a breast cancer, unfortunately, and I did the surgery. And subsequently, she did needed some post-operative chemotherapy to keep the cancer under check. And she did not show up for chemotherapy. So normally, healthcare is very disparaging to these people. They always call them non-compliant patients. That means these people don't want to get well. They are not interested in getting the things. So it's a waste of our time trying to give them the medical health care because they don't really interested in getting themselves, controlled, cancer controlled in a way we expect them to do that. But I didn't want to really brand them as non-compliant patients. I just wanted to know why she would not come. Because I know her little background. She is an Hispanic woman who came to this country and, actually being undocumented, and they lived in Queens for many years. And she worked hard and she put her children to school and college. And she has been a very valuable, hardworking person in the community. And she's especially very God-fearing, religious. And I really want to dig a little deep. Why would this lady who has been so good during the entire treatment period, why would he not come to do that? Then I found out that she lives in an apartment. And the landlord of the apartment found another tenant who can pay more money to her. So she basically threatened her to evict her. And she told her that you are undocumented immigrant. If you leave, I'm going to change the locks and you have no recourse because you can't go to the authorities because they are going to deport you. Because that's not true. But she did not understand that. She felt that she always living in the shadows, looking always behind her and say, hey, is somebody going to come and deport me and take me away from my family? And so she has an option here. One, come to chemotherapy and being locked out and being homeless and being deported, or forego the cancer treatment, stay in an apartment, a prison in own apartment. That was a defining moment. Here we are. We gave the best of treatment to her, the best of surgery, willing to offer the state-of-the-art chemotherapy to her, but it is not useful to her because there is something else which is impeding her access to the care. She wants it, and she also deserves it, and we're willing to offer it to her. So that basically moved on to say, why is that happening? Because we always looked at healthcare from scientific perspective. Okay, you have a disease, I give you medicine, you get cured. If you don't get better, I'll give you another medicine. At the end of the day, we basically did not address the social issues for many, many decades. Healthcare always compensated the social issues with more medication. For example, if you're a diabetic and you happen to live in a food desert where there is no healthy food available, or you don't have any fresh food available, or you don't have the money to buy the healthy food, and then your diabetes will never get better. So the only way for me to control diabetes is not to get you the fresh food or the access to the healthy food. I give you more medications so that your diabetes come under control. So we have done that consistently in this country. We always try to compensate what we have to need to do socially. We compensate them with more medication. So no doubt we call ourselves the pill nation, right? Because the nation of pills. We have pills for everything. And that was a life-changing moment for me. So I basically left my surgical practice. I need to focus on why this happened and how can we, as healthcare leaders, could be change agents to make this happen. So that is my passion, and that is what driving me all these years through the multiple public healthcare systems and multiple governments trying to achieve what we need to get as a nation to be equitable nation in healthcare and social issues.
What a story. I'll tell you, there's so much in there in terms of encapsulating the issue. I mean, across the board, there's no doubt about that. I think also your comment with respect to medicine and I guess I would say the resources that were put into this individual's care when there were so many other issues that they were dealing with that clearly probably created, at the very least, a horrifically stressful experience, which didn't make it any better for her as a patient. And also, besides the clinical implications, added cost, inconvenience, et cetera, so much of what we talk about with respect to the social determinants. I wanted to ask you, just so we can level set, Dr. Raju, your definition of health equity and health disparity. Can you just, for me, for our listeners?
Sure, absolutely. Yeah, absolutely. I think health equity, as defined by CDC, is that it is a state in which everyone has a fair and just opportunity to attain the highest level of health. In other words, we understand health will not be, everybody will attain the greatest health possible because but our idea is they should attain the highest level of health for them. And we need to create an opportunity for everyone to do that. That should be fair and that should be just. That is what health equity is. So that's the end stage of the game. Health disparities is a present state. It basically defines why the disparities exist. Why is that we treat somebody with the same medication, the same doctor, the same amount of expertise? Why the outcomes are so different? Why is that the infant mortality rate among the black children in Harlem is higher as opposed to the white children? Why is that we have the diabetes rate and the outcome of diabetes in Mississippi is so high compared to the rest of the country? So we don't do anything different. We have the same medicines, we have the same doctors. So the question in healthcare disparities, we try to understand what is that, the present state, which creates these different outcomes for different people. So what is the present state? Health equity is the future state, where we are able to give everybody a fair and equal opportunity to attain the highest health level possible for themselves.
Okay, and with respect to the social determinants, because I think a lot of what clearly in the story that you told about the woman from Queens who's undocumented, so much of that also kind of clearly went over into what we call the social determinants, including, I think, the references you just made with respect to where folks live, the op-ed comparing Streeterville in Chicago with other areas, showing how zip code and where you live can make such an incredible difference. Dr. Raju, your thoughts on the social determinants across the board, and let me do a follow-up with that, which is, what can we do about that? Because that's the other piece. I don't want to jump quickly to solutions, but I think the social determinants, they're so all-encompassing. Mm-hmm. And where do we? Is it a political solution? Is it a structural solution?
Sure. I think in somewhere in the early 70s, we united the human services with health, and that's why we were Secretary for Health and Human Services. That actually started with under Richard Nixon, right? But in spite of that, over 50 years has passed. We do not know how to integrate the human services with the health services in this country. So human services exist on a silo. So they understand and they have all the data regarding the food insecurity. They have the data regarding transportation. They have the data regarding homelessness, mental illness, poverty, intergenerational poverty. All those things are assigned on one side. The other side, we have the healthcare, and the health contains all those enormous amount of data, from the public health data to healthcare data to everybody's data. No one is just uniting them as a part of it. What it means in a basic level, the level is that I, as a physician, know more about your diabetes. I know what your last blood sugar was, what is your last hemoglobin A1C level. I understand what advice I've given you to eat, all those things. But I know very little about you. You as Rick, who are you? Where do you live? What do you do with it, right? Because my instructions to deal with this problem may not be suitable for you, because you happen to live in an area. I tell you, Rick, you have to do every day. You have to walk 2 miles. That's good for you, because that way you burn your blood sugar, and then you are going to you get your weight down. That will help you with the diet. But you happen to be living in a public housing which is on the fifth floor, and 95% of the time the elevators are out of function. So you are basically have to go down 5 floors and get up 5 floors to make a walking every day, which is almost impossible. So you are basically a prisoner in your own apartment. I don't realize that. Or you happen to be in a neighborhood where you can't walk because of public safety. We don't know anything about that. We basically say, Rick, do this as a part of it. And then we know little about you, but we know nothing about the conditions you live. So that is the problem. That data is available on the human side of the thing, human services side, right? But I don't get the data. So if I want to treat diabetes, I need to know where do you live, right? Where are you able to live and able to do what I ask you to do? Eat healthy food. Do you live in a food desert? Do you have enough food, money to buy the food? Or do you are able to walk and take the exercise in the neighborhood, which is safe for you to do that? Do you live in a place where all these things I ask you to do, will it be done? Healthcare never worried about. Healthcare was basically disease treatment, and that is it. That's the way we looked into that. So what I was trying to do is, I created an app for my last job. We basically created what we call a social vulnerability index. In other words, if you come in, you answer 15 different questions about your social status. Again, it's very easy because the Z codes, which is using now, and ICD-10, basically helps you to capture the social issues. But nobody's capturing it because there is no money reimbursement involved in it. Because we pay according to the CMI, how in the case mix index, which how severe the disease is, but not according to the social issues which are involved in that. And as you rightly pointed out, if you have the same CMI, case mix index, severity of the case, in one zip code, and if you have to be another zip code, the cost is enormously different, which we have shown that repeatedly. So we created this app in which you are basically answer 15 questions. We based on AI in the background, we basically classifies you how risk you are socially, 1 to 10. If you're more than 6, we basically allow you to refer to the various social service organizations. It could be not-for-profit, private, right, government agencies, whatever it is. If you're homeless, then we refer you to the various agencies, to the clergy, local organization which help you with the food insecurity, the people who bring you Meals on Wheels. Or in New York, we work with the organization called In God's Love We Deliver. They basically deliver food to the people who homebound. All those things we are able to do that and showing people that you don't have to increase the medication of this person. Let me address these social determinants of health or social vulnerability index. We showed in over 200,000 patients, if you bring the social vulnerability index down, then you see the health outcomes improves. So we created this app whereby you not only will look at your clinical risk factors, we also look at social risk factors and combine both of them. Thereby, we are able to go to the local community-based organizations and government agencies and for-profit, not-for-profit organizations and connect them to the patient, because we understood the health care cannot be delivered in isolation. It has got to be together with the community-based organizations. And the most important thing of all this thing also health literacy. We have to make the people understand why we ask them to do what they do. Unless we get the literacy up, we are having a problem. So for that, we create another app. Whatever the hospital or the government want to push it out, it comes through. We did this together with an organization, it's a startup in the West Coast. Basically, what it does is you put the message out. Either it is a message for how to take care of diabetes, what kind of diet we eat, or what do you do in COVID, what do you mean by social distancing, how do you wear a mask, whatever the message, right? The person who gets it adjusted to what literacy level he, she, or wants. She reads it. She doesn't. She's on the 5th grade literacy. She doesn't understand it. She clicks a button. It goes down the 4th grade literacy level. In the AI in the background, that's the same thing available. And you also have this app at the great advantage by which you can choose the mode of your education. Some of us are visual learners. Some of them are audible learners. Some of us are basically read a paper and learn from it. But in healthcare, we never understood that. We always gave them a piece of paper and said, these are the instructions, follow them, right? Whereas this app, basically, you can choose which is the modality you want. The same message could be given to you in a video form, or it could be an audio form, or it could be just a piece of document which you can read through. And of course, you have the Google Translate in the background. You can also choose the language in which you want it. We use this extensively in COVID, and we found the message reaching people, reach them better because they are able to adjust they understand the message in the literacy level of their choice, the modality of their choice, and also the language of the choice. So these are the two major issues which we need to do to combine the human resources function with the health functions so that we are able to create an equitable healthcare equitable organization.
And that was fantastic. And what I'm hearing in there with the social vulnerability index, the app, really looking at, I would say the educational, the literacy side on a health literacy perspective, how you could leverage technology, I think, if I'm hearing you correctly, to really increase access, which is fantastic. My follow-up to that, Dr. Raju, is this. So clearly there's a benefit to it. How do we scale that? And who pays for it? Because there's utility. Does this fall upon health systems and obviously the changing role of hospitals and health systems, say in a community as part of a community trust? Or is it a federal play? Where is Medicaid on this? Your thoughts on that?
Okay. So we need all three people to be involved in this. As I always said, the healthcare has got three main components. One is the government, because they're the biggest payer. Number two is healthcare organizations, healthcare systems and organizations that include the providers and everybody. And the number three is the health insurance companies, right? There is an advantage by health insurance companies because by addressing some of the social issues, they were able to reduce their cost of care for the patients. An example is we had a pilot project with one of the largest health insurance companies, showing them that offering them a free Uber or Lyft services to their doctor's office, which cost them like $20 or $25, saved them emergency room visits the same night because people have nobody to take them. They have no transportation. Some of them live in a very transportation challenged area where this is not available. For example, Nassau County in New York or the middle of Iowa, Utah, whatever areas you choose, geographically inaccessible transportation-wise. So we told them that if we can just give them an opportunity to use it, they don't have to wait for a family member to drive them because they can't drive themselves. By giving them this, you are able to reduce the ED because if they don't go to the doctor's office, they end up in the emergency room in the middle of the night because they did not get their medicine adjusted or they don't understand what it is, and that's what happens. So we were able to show a better management of the patients, cost-saving management of the patients by working with the insurance company, number one. Number two, we testified multiple times before the Congress asking them to start paying for social risk factors. Because as I said before, there is an opportunity in ICD-10, Z codes, to capture the social risk of the patients. And I've shown repeatedly with multiple publications and op-eds and everything else that I was able to show that the social risk factors increases the cost of care because of the social issues they deal with. For example, a person in a public hospital, the discharging process of them is more expensive because they have nowhere to go. We have to send a social worker to make sure that they have enough food in their house or their living conditions are good, there's enough heat in the place. All those things are more expensive than a middle class or a upper middle class person going home because you just have to give them a piece of paper and say they find their own transportation home. Whereas you work in the public system with me, our social worker need to make sure what the transportation needs are. Do the houses refrigerated? Do they have enough humidity controller? Or they have enough the food in the refrigerator? Or they have heat in the house? All those things. That is expensive for the hospital system. So hospital systems should really start collecting the data. They'll be able to make a much more persuasive case with the government, saying that we need this as a part of reimbursement. And the government should also know that they are spending this money on the various social services. But connecting them to the healthcare, they will find it to be better bang for the buck than what they're doing today. So we need all three of them coming. Insurance company need to understand this is a really cost-effective mechanism as well as the better patient care. Healthcare system need to understand by capturing the data and submitting it to the government, able to show that that it is so intricately related, the social issues and the health outcomes, and it costing more money by doing that. And third is the government need to step up and say, you know something, I have a mechanism to assess by Z codes, so I am going to change the reimbursement technology by which I'm not only going to pay you for CMI, the severity of the disease, I'm also going to pay you for extra for the social risk factors. So all three need to come in.
Fantastic. You know, I think back in the roles I served, particularly in the C-suite as a CEO, where I looked for maximizing margin. It was part of the job, besides obviously clinical outcomes, patient experience, employee engagement, but financial performance and fiscal responsibility was part of that. And the calculus we used was reduce length of stay, discharge people early, avoid admissions if you could, optimize DRG, look at your payer mix, et cetera. I think what you're really calling out here is in leveraging technology and managing the entire continuum of care, you can do all of those things, but the most important is the clinical outcome side. I think with respect to reimbursement, again, most an N of one, my experience, most CEOs, most health systems are working within the reimbursement structure they have, and they don't have the kind of flexibility. Where do you see things going with respect to the role of health system CEOs and CEOs? Is it now being part of the community trust going to go over into housing, even looking at, you mentioned food insecurity. I thought of my time in Chicago. I know when you led Cook County, when it was really freezing outside, we opened the lobby for folks who had no place to go. I mean, where does it start? Where does it end? Is it now part of the portfolio of the CEO and health system leadership?
Okay. So that's a very interesting question, right? This is what a lot of CEOs try to, struggle with. They try to solve it and they struggle with it. In 2002, we proposed a concept that hospital has got no walls. We have to think of healthcare not only within the four walls of the hospital, because you are responsible for the healthcare even outside the four walls. So we promoted a concept. I still remember that, when I gave a keynote speech in 2001 or 2, I think I forgot, I said, hospital has got no walls anymore. So do not confine yourself to the walls. You look at the patient all the way through. So that concept took a long time for people to assume responsibility. Now they do, because of the value-based payments, because of the contractual obligations, risk-based contract, and all those things which came in. People say, okay, I need to own the patient care outside the hospital also. So I need to really make sure what they do outside is as important to me as to that. And the IPO and IPAs came in. All those people really take a risk on their reimbursement. They all wanted to be a part of that. That's one thing. Then the second impetus came in there with what we call as the community benefit dollars. Because not-for-profit in this country, hospitals are not-for-profit hospitals in the country, get a lot of community benefits because they don't pay income tax, they don't pay property taxes, they do not pay sales tax. And there is a lot government gives it to them to provide health care. The question is always, how much of that money you gave back to the community? So what is your community benefit dollar? So under the Obamacare, we were able to make the hospital systems report their community benefit dollars, as a form of their tax returns. It's called Schedule H for Harry. And we are able to now monitor how much of money you gave back to the community for all the benefits you got. That you didn't pay income tax, social, you didn't pay income tax, you didn't pay property tax, you didn't pay sales tax. All those benefits you got, how much you give it back. If you look back at it, it's a very minuscule amount of money you gave back to the community compared to what it is. So more and more healthcare leaders are saying, okay, fine, now I have to figure out how to do more community benefit. So I need to really create a park near me, right, to do that. I need to create employment. I need to create. So with that on board, we created one of the founder members of an organization called Democracy Collaborative, which basically asks the CEOs to do three things: hire locally, right, and spend money locally, and invest locally. So you improve the local economic condition. As I first said that, if you improve the economic condition, social equity comes. Social equity leads to health equity. So most of the organizations are better use the community benefit dollars instead of just wasting away on one-day affairs of health fairs where you go to like I used to call them, carnival in town. You just go there, put up a tent in a playground, and you basically take the blood pressure pulse and you give them some chocolates and you have some balloons, and then you go back and say, okay, we trained, we looked at 100 people and we found diabetes in 10 people. If you remember these people, these are the guys who really have diabetes for a long period of time, and they are basically the same guys. These are carnival goers. They go from carnival to carnival, and that's why they get checked out, because they really didn't have anything. But if you look at that, these things cost like $30,000 for a one-day affair. So you have to pay nurses overtime, you have to pay doctors overtime, you have to put all the things in there. Everything costs money. Instead of that, they could use that money to do something better. For example, I work for an organization in Long Island. Their organization, health fair, conduct like 1,200 health fairs during the entire summertime, because there's a big system in various places. Every health fair is like $30,000. I showed them $30,000. We can send one school kid, secondary school kid, home every day with a food. Because these kids, when they go home, some of them are single mother, single parent, and the parent works at home and he does his job. He doesn't come home, he or she doesn't come home till 8 o'clock. The children have got nowhere to eat, so they go to the nearest McDonald's or the fast food and they eat. Instead, would it not be nice if I just packed them some nice food to take it home at night so that they can eat healthy? Because childhood obesity is the next biggest epidemic, which is going to kill the economy and the healthcare in this country. So we're able to show them. So more and more CEOs understand the need of how to invest in the community, how to develop a community benefit program, how to be a part of the community, how to be a change leader in the community, not just healthcare giver, just a change leader, a social change agent in the community. So that is happening. So more and more people are not looking at it anymore as all the things we talked about, length of stay, reimbursement, all those things, but they also start looking outside to look into that as a part of it. And one more thing, a lot of the non-healthcare systems, because we need to figure out how to interact with the non-healthcare systems. Non-healthcare systems has got what we call as CSR, the corporate social responsibility. And they're really looking for avenues and opportunities. How do they render this corporate social welfare? An airline company I dealt with, they basically said, could you help us to figure out how do we discharge and be able to do our corporate social responsibility? I told them, you live in a place which I showed them by Department of Agriculture statistics is a food insecure area. You can actually create a supermarket. You can actually have the whole food come in and you can subsidize it as a part of it, because people in the neighborhood can buy it, because people cannot able to buy this healthy food. You can really use that as a part of it. You don't have to, because their only transport corporate social responsibility idea was, whenever there's a hurricane or something, they fly the healthcare workers free of charge. That is what they say. I said, it doesn't have to be. You can work with a local healthcare organization, try to understand what is the prevailing health need of the community. And you can work with them to do that as a part of it. The prevailing need is a lack of vaccination or lack of housing, whatever it is, you can do that. And some organizations have done very, very well. ProMedica in Iowa tackled this healthcare food issue very, very well. And the organizations in Cleveland has worked with the thing to build housing for some of the homeless people. So there is a more and more awareness of the CEOs. They're not only looking beyond that, and the boards also started selecting CEOs who has got much more wider community understanding and access, as opposed to just somebody who is very good in managing the day-to-day affairs or the finances of the organization.
That I think you're spot on with that, with respect to the core competencies and changing over time for healthcare and health system CEOs. I mean, now clearly with the challenges that are out there, it is the time, and I think our academic institutions that teach in higher education with respect to health administration are recognizing that. One couple of other quick rapid fire questions. How about in the consumer space, when you look at the Amazons, the Walmarts, even Dollar General now announcing they're getting into healthcare, what is the role that they should play with respect to, I would say dealing with recognizing healthcare equity and the disparities that exist? Is there a place? Is that a fair question when you think about these organizations, since they clearly are, I would say, playing in the health sector?
Yeah, absolutely. I think I've been in contact with one organization such that where they are trying to create a lot of primary healthcare accesses, because, as you know, the pharmacies have got more access available than the healthcare delivery system. Because as I looked at this study, which showed that there is a pharmacy every 1.5 mile kilometer throughout the country, and if they get into the primary care practice, then their access issue becomes moot as a part of it, because they have more access available, and they're also make it more convenient, and it's also in the business model, because people come in, when they come to the pharmacy, they also not only get healthcare, they also buy what we call impulse buying. They buy things as they go along. So that is a market strategy for them. So by offering this healthcare in some of these pharmacies, and that has become very, very good. So I believe that in a longer period of time, most of the primary care in this country will be offered by these big, pharmaceutical chains, pharmacy chains as a part of it. And the hospitals will only for the really sick people, and people what was originally supposed to be normal hospital admissions will all be intensive care admissions. That's what will happen. Hospitals will become more and more of high-level intensive care, and more of primary care and the routine care will be given in those pharmacy-based chains as a part of it, because people don't want to wait long time and they want to get quickly in and out. They also want convenience as a major factor. Because if you look at it, that's what the consumer wants. The quality is given. You can't really run any more organizations saying I get the best quality care, I get the safest care, because that is given. Everybody assumes that you will give good quality and safe care. People want convenience. How quickly I can get somebody. Apps like Zocdoc basically tells you can go to 5 doctors. This doctor has got 20 minutes waiting time. This guy has got 10 minutes waiting time. So you choose a 10 minutes waiting time, because the new generation basically want convenience more as a part of it. So the things are changing. So healthcare needs to understand that collaborate with these organizations. For example, healthcare X should work with the pharmacy chain B and say, okay, you run the primary care, and I will help you with my doctors run the primary care. So whenever the patient needs admission or something, you refer them back to my system. So we are having this opportunity to create a better healthcare model, so that I don't have to provide everything from A to Z. You provide some, I take care of your complicated patients. So that collaboration needs to develop. So for example, healthcare A should be working with the Walgreens, saying that, okay, I want to work with you. Healthcare B would say, I work with you CVS, whatever it is, right? So the future model is primary care will be more accessible. It is convenient. It is available in the pharmacies which are near you, and you don't have any waiting period. You can walk in and get the care. Those are all the the checkpoints in which you have to really create an accessible, convenient healthcare system. You got to move away from creating a healthcare system based on touting the quality and safety, because it is given. No hospital is going to say, I give poor quality and my care is not safe. That's not happening. Everybody gives quality care. Everybody claims to give safe care. So that is no way of differentiating that. There is nothing to differentiate that quality of care. So I think the things are going to change, and the hospital system needs to understand quickly, start developing these relationships with for-profit outside the healthcare provider space, like pharmacies and other things.
Yeah, I've looked a lot at obviously the pressures that are there, upward, downward pressures, the economic, et cetera, including the demographics. And there's no doubt models of care and what you just described is I'd say it's more of a pathway. It's happening right now. Just absolutely fascinating insight with that. As we wrap things up, Dr. Raju, last thoughts from you on, the future of healthcare with respect to equity, disparities, anything that's on your mind for the Healthcare Nation audience.
Yeah. No, I think it's time healthcare understands the value of the technology. Because, I would say one good thing came out of COVID is that people learned how to provide healthcare through telemedicine. In fact, I sat in national committee to look at the health telemedicine and set some guidelines. And we surveyed the people who took healthcare during COVID through telemedicine. 87% of them said that we would stick on telehealth. They basically said, I'm happy with that because I don't have to wait for it. Whenever the doctor is ready, they call me. I get on the thing. I'll be able to do that. So 4 years ago, the doctors would have really resisted that. They would say, no, my patient wants to see me. I won't touch them. There's nothing like in place. The patients are quite happy to do that, because of COVID, it's made it necessary, but people come through that. So the technology is going to be different. And then with the technology and the AI coming in, machine learning and wearables, which are in there. I sat in one of those recent competition as a judge. I was amazed by the wearable technology. I had one guy basically trying to get a venture capitalist funding for a wearable which measures 17 different things, including this oxidation, temperature, pulse rate, blood pressure, and EKG, right? So we need to adopt those things as a part of it, be able to deal with that. So that is coming. The change is coming, right? And as Bob Dylan used to say, the change is coming. People are not going to be part of the change. They're going to be swept away in the change. But from the health equity perspective, be careful. Because when I first went into healthcare, into the equity space, and looked at the vulnerable communities, I looked at the vulnerable community through the ethnic and racial angle. I looked at it, Hispanic, Black people who are not able to get healthcare. As I studied it more and more, the vulnerability population increased exponentially. Then I found out people are vulnerable because of lack of insurance status. People are vulnerable because they don't have immigration status. People are vulnerable because their sexual preference, right? We all know LGBTQ people don't get the adequate outcomes they're supposed to get. Then there are outcomes because based on age, disability, intellectual disability, so many things. The vulnerable population expanded over a period of time. But now with the telemedicine, we'll be adding one more vulnerability, what we call as the digital divide, where I happen to be in an area where there is no free or high-speed internet available to me, then I'm disadvantaged. Now I become a vulnerable population. Or I do not have the technology or the knowledge to know how to manipulate or get into this telemedicine space. Now I became a vulnerable population. So we need to be careful as we develop this, because as we are developing the technology very quickly, there are also going to be some create an inequity in the part of it. But that does not mean we should not create. We have to move to the modern age of completely exploring and utilizing the technology, which has got a lot to offer to healthcare. We have been resistant for so many years, because we ran the healthcare like a cottage industry for nearly 4 or 5 decades. Now the time has changed to move into the newer model of doing that. So I'm all for technology, but with the warning, watch out for the people who will be left behind because they don't have the wherewithal to be able to participate effectively in the new modalities of medicine. So I was actually proposing to the most of the healthcare companies, including the government, like you give a free gym benefit because you want to keep your people healthy. You want to give a gym benefit. Give them a free, internet connection. You know how many is it? $10, $15, $20? Give it to them, right? And I'm very happy to say that Biden administration have actually taken this on as a part of the equity thing. They said they want to offer high-speed internet to most of the country so that people are able to communicate with each other. So, good things are coming. Technology is exploding. The modality of management is changing. People are receptive to that. They accept the telemedicine as a modality of care. All good. Watch out for creating another vulnerable population and another health inequality. Thank you.
Well, on that note, Dr. Raju, thank you so much for your insights, obviously sharing your experience and what you've done, I would say, for the people here in the healthcare nation and the lives you've touched over your incredible career. I know much more to come, and we'll see you again on the Healthcare Nation podcast. Thank you, Dr. Raju.
Thank you very much, Rick. It's a pleasure to be here.